Yeah. Good afternoon, everyone. Thank you, AIOC, for inviting me here, especially Dr. Amit. And I would be talking on principles in initiating medical therapy in glaucoma. We have had an extensive talks about various glaucoma management from other speakers, and I would be basically talking about the principles. These principles are basically just the guidelines. They are not hard and fast that we have to follow each and everyone to the book. But yes, these guidelines have to be for every patient. We have to monitor and modify accordingly. So we know that glaucoma is a group of diseases characterized by optic neuropathy, leading on to visual field defects, and which may or may not be related to increased intraocular pressure. But it is just the tip of the iceberg. And diagnosed cases are much less than the undiagnosed cases. Now, the treatment options that we have available with us are the medical therapy, the lasers, and the surgical therapy. And of these, the basic principles are based on these three parts, like the age of onset, the rate of progression, and the amount of visual field loss. These are the important parts that we should look into. And these are the things that will determine how we control the IOP later on. So if we see at this graph, this normal, we will see that this is the normal aging process and the RNFL loss occurring in a patient. While this one, a good controlled glaucoma patient has this type of graph over a period of time. Then a person who has been detected glaucoma at a later stage or who develops glaucoma at a later stage will have this type of a graph, and we know that we don't need to go too hard on him because of his lifespan, and we can modulate the therapy accordingly. While a person who has been diagnosed at an earlier age, like here, and he's likely to get a functional loss during his middle or sometime later in his life. So we need to take care of these kind of patients who need to, if they're not treated properly, they'll go this way, where they will have a steep downward curve. So this is how the first one was, that diagnosed late, but developing slowly, and we need to set the target pressure accordingly. While this one is the second one, which was diagnosed early and has developed the same amount of loss at a much earlier age. And these are the patients that we need to take care of. And these are the ones who we need to set a target pressure to. Otherwise, they would go steeply down and they will develop a defect. So this was the protocol given by the American Academy of Ophthalmology. And they have given that we have to categorize basically the patients, open angle patients, into ocular hypertension, primary open angle suspect, and POAGs. And we know that OHT suspects can be a low risk or high risk. Low risk if they have no other family history, no other myopia or other risk factors, and they can be reevaluated every 12 months. While high risk factors having higher IOP range, like more than 25, but without any field or defects or anything in the disc, they can be reevaluated 6 to 12 months. Then POAG suspects, again, we can consider they are the disc suspects basically and have maybe a risk factor. They can be evaluated earlier at 6 months. While POAG patients, we have to establish a target IOP, and ideally 5 to 6 visual fields have to be done within 2 years so that we can determine that the progression is occurring or not. If they're stable, then we can reevaluate every 6 to 12 months. If they're not stable and there is a progression, then we need to either change the treatment, set a new baseline IOP, and then reevaluate even earlier than 6 months. Similar for the patients of suspected angle closure glaucoma, if there is no peripheral anterior synechiae normal disc, these have to be followed up, repeated gonioscopies. While if there is a peripheral anterior synechiae, then again we need to go for a iridotomy. While if there is a high IOP with PAS and with a glaucomatous disc, again iridotomy and then manage according to the primary open angle glaucoma. So the principles would be that earlier the onset or detection, the more strict should be our adherence or monitoring. It is advisable to have at least 6 visual fields or 5 minimum in the first 2 years to document progression. And set a reasonably good target pressure. So target pressure is what pressure? It is defined as a range of intraocular pressure which is adequate to stop progressive pressure-induced injury to the optic nerve head. Or it can also be defined as the IOP at which the rate of ganglion cell loss is not greater than the age-related loss. So this is the most important part that we should look into. But there is no clearly defined single IOP level below which the individual is completely safe from developing glaucoma. This was given by Baltimore Eye Survey and Normal Attention Glaucoma Study. And to set a target pressure, it should be based on severity of the damage, height of the IOP where damage occur, and the longevity of the patient, the central corneal thickness, and the family history. These are the things, and to set the target pressure, it should ideally be set, that target pressure should be lower than the daily variation, the lowest pressure that we record in a day, the variation, and it has to be more than that. Generally, less than 30% is taken, the IOP has to be reduced more than 30%. And as a rough estimate, if there is a field loss, mild field loss, it should be around 16 to 18 millimeters of mercury, moderate 14 to 16, and severe in 12 to 14. It can be even lower in normal tension glaucomas. So a POAG, we have to establish the target IOP. If still there is a progression, change the treatment, readjust the target IOP, set a new baseline, and follow up for less than 6 months. Now, to start a glaucoma therapy, monotherapy is preferred unless the pressures are too high. Prostaglandin analogs and beta blockers are usually the first line of drugs, depending on the patient's age, the patient's pocket also, and the side effects, if there is any systemic illness also. Alpha agonists and carbonic anhydrase inhibitors are second line of drugs, and Rho kinase inhibitors are showing a much good promise. So if we start with this therapy, they are well tolerated, and if well tolerated and a target IOP is reached, then we do a periodic endpoints are verified. While if the target IOP is not reached, we add a second drug, and still if it is not reached, then we substitute the drug or verify the efficacy. Other therapeutic options are surgery and laser, and if it is not tolerated and not effective IOP control, then we switch the monotherapy or consider laser till the target IOP is reached. So the general principles would be set a target pressure, consider the systemic health of the patient. Always consider whether the patient is suffering from any other systemic illness, consider the cost of the patient, cost of the drug to the patient, consider the lifestyle, and consider compliance. So be very realistic, because if a patient with advanced glaucoma has an IOP of 30 millimeters of mercury on 3 agents, adding a 4th agent is not likely to bring the IOP further. You can go for an early surgery. So very important to be realistic in your approach. The drugs, as we all know, they either decrease the secretion or increased outflow. And beta blockers, alpha-2 agonists, and CAIs are the ones who decrease secretion, and the trabecular and UV scleral, increased outflow is by trabecular and UV scleral pathway. And we all know, I'll just skip these because these are, we all know, beta blockers, prostaglandin analogs, alpha-2 agonists, they should be avoided in young because they can cross the CNS barrier. So we have to avoid them. Dorzolamide, brinzolamide shows very good results. Osmotic agents only for acute purposes. Miotics, thankfully we are getting pilocarpine now from today onwards. And maybe because we were also using the carpinol injections for our patients for PI. And Rho kinase inhibitors are very good drugs now available to us. And these are basically the effectors of Rho pathways. Rho pathways are responsible for the cell motility, differentiation, and apoptosis. So to prevent this apoptosis, these Rho kinase inhibitors are there, and they have shown very good results in corneal wound healing also. In glaucoma, they improve the direct action on the trabecular meshwork and Schlemm's canal.
Sumit, can you sum it up?
Yeah, I'm summarizing. So combination therapies need to be looked into because combination will reduce the cost and the side effects. So if it is the patient who needs to be treated, so be certain that the patient has an active disease and needs treatment, because no one will have the courage to stop the treatment that you have started. And overall, there is a modest penalty for delaying the treatment in OHT subjects. This penalty is minimum for low-risk patients, but saves a lot of eyes from being unnecessarily treated. And thank you. Thank you so much for this.
Thank you, Sumit. So till Deven is setting up his laptop, take a quick comment on this from Dr. Manisha, sir.
So he has covered the topic very well about the medical management and the basic principles that we have been put. And I would like to stress the fact that he's outlined how to calculate target pressure. Your method to calculate target pressure has to be simple and straightforward because you have to do it day in and day out. Only point is that certain risk factors are to be given additional importance when you calculate the target pressure. So over and above what he said, we can give more importance to patients who have got pseudo-exfoliation, thin corneas, who are showing recurrent disc hemorrhages, and and also people who have got a family history of vision loss. Family history of glaucoma is there, but vision loss is a separate history, which at least I ask, because people who have become blind, parents who have become blind, their kids would carry a much higher risk of progressive glaucoma, so that should be kept in mind.
I think just one quick, emphasis. Basically, he mentioned the slide in the chart which was shown. I think that don't miss the angle closure disease, because most of the time, unless we look for angle closure disease, I think we often miss that. So we have to be mindful of the certain phenotypes which are more likely to be misdiagnosed or underrated, and angle closure is one of them. And pseudo expression, as and he's already mentioned.